All right, everybody, welcome to this Heart Rhythm Theater session. We're going to get started. We have a packed agenda today, so we want to make sure we get everything in. This session is Shaping the Future of Cardiac Ablation, and we're going to be discussing some fundamental concepts about PFA and showing you the clinical relevance of that based on preclinical and clinical work, and really focusing on contact and using the science to enhance the durability of PFA lesions. So my name is Shephal Doshi. I'm from Santa Monica, California. You see I have an astute group of colleagues to my left. We have Hiroshi Nakagawa from Ohio. He looks like he was born and raised in Ohio as he sits there. Then we have David Kenigsberg from Florida, Jacob Koruth from New York, and Jim Hansen from Denmark. So we're going to have a few different topics in terms of how we cover this, and hopefully we can put it all together fairly quickly. So in the interest of time, I'm going to get right to the first slide. So I'm just going to start the intro off and just kind of give a 35,000-foot view of pulse field ablation, discussing some fundamental basic concepts about waveforms and the importance of the generator and what it can do and how it interacts with that, discussing monopolar, bipolar, voltage, and current. So I think in this audience, it's always nice to have a kind of overview, and basically what we're doing with pulse field causing electroporation is delivering a high-intensity, high-voltage electric field for a very brief period, whether it's a microsecond or whether it's a nanosecond. But what happens is when you get the field right, you're going to disrupt the cell membrane, causing irreversible electroporation like you see in the image there, which ultimately then will lead to cell necrosis. And I think, you know, compared to what we just consider to be thermal energy sources, whether it's heat or cold, PFA is largely non-thermal. There are some thermal effects, but you know, generally speaking, not ablative thermal effects. And this is really related to the waveform, the design of the catheter, the generator, the shape, and all these things. And the reason why the field is taken off, and if you saw Thursday's session, you know, on PFA, there were over 1,000 people attending just to kind of get this introduction to PFA. The reason why there's so much excitement is this lower risk of what we perceive to be collateral damage, and to be able to do an efficient workflow so we can manage more patients. But just looking back, the way most people think of PFA is that cartoon where PFA, you know, then something happens, the next thing you know, you have a lesion. And you know, this is one of those energies that has reached a clinical kind of space without us really explaining it and educating our colleagues and really having a deep understanding out in the community. So, you know, the way things started was, you know, just with the basic waveform, monophasic, and I think most have transitioned to a biphasic waveform. But I want us to speak briefly on current versus voltage-controlled energy delivery and some of the theoretical advantages and disadvantages, or strengths, I should say, of monopolar and strengths versus bipolar. So when you think of monopolar, right, the concept is the same. The energy goes from the electrode to the dispersive patch. When you think of bipolar, it's electrode to electrode, and on the left you see some catheters that can deliver monopolar energy, and on the right you see these larger volume, what are called single shot, but at least do larger regional type ablation delivering bipolar. And if you think about monopolar, remember you're emitting the energy from the tip of the catheter going to the dispersive electrode, so you tend to get deep lesions. Now, of course, this varies on how you power this and how many volts you use. But one of the challenges can be, unless your waveform is tuned correctly, many of the monopolar configurations that are commercially in use or being tested cause some skeletal muscle stim. But there are some, which we're going to talk about, that don't tend to do that. So it really has to be with how the waveform is designed. And then the benefits of bipolar, obviously, is having contiguous lesions between the electrodes, right? And when you have bipolar energy delivered, there's less susceptibility to muscle contraction, which might lead to some workflow advantages. If you potentially don't have to intubate, you don't have to paralyze. But you know, the challenges with bipolar design, as we've seen recently from other bipolar catheters, is unless the electrodes are done correctly, coded correctly, spaced correctly, you can get high temperatures and you can cause thermal effects and charring and bubbles, which is a sign of that when you use these types of catheters. So there's basically conceptually the concept of controlling the current versus controlling the voltage. And that little cartoon up there is really is Ohm's law in a kind of a funny way of looking at it. So if you take a current control where you're applying a certain amount of amps you set that amperage, and then the voltage will adjust to keep your current constant. Versus if you're doing voltage control, which you see in the bottom in the blue panel, the current will adjust to keep your voltage constant. And that's what we see with bipolar. So why does that make a difference? And if you think about the way energy travels, right, if there's a variability in resistance from patient to patient, then the only way you can compensate to keep the current constant is by adjusting the voltage, right? So a larger patient, you'll need more voltage to maintain the field, smaller patient, less. If you're doing bipolar energy, since the energy is traveling between the electrodes and the resistance is really related to the contact of the electrodes, you basically maintain a current change. So you change the current to get that voltage to stay constant. And so obviously if you have higher tissue contact, you're going to get less current that will be needed to maintain the field and vice versa. And so this is just a concept, again, showing of the things we're going to talk about, of using monopolar energy with the correct waveform, with catheters designed, whether it's a solid tip focal, large tip focal, and then the concept of bipolar energy for a larger profile catheter that can do more single shot applications. So with that, I'd like to introduce Hiroshi Nakagawa to come up to the stage. I guess you can sit and talk. Is that all right? There's no stage here.
Yeah, already.
Yeah, they'll pull your slides up. Here's your advancer.
How you do that?
There you go.
Huh? Okay, coming. All right, so I'm talking about the role of contact force in the PFA ablation lesion durability. Here's the disclosure. Okay, here's one of the multipolar circular PFA catheter, which has like a 9 French 9 gold electrode. One application containing 4 burst strains. First burst strain eliminate the all potential. All right, this is usually a case. Boom, all gone. Question is it good news or bad news? That's what I'm going to talk about. So we know the circular catheter never have the perfect circumferential contact. This is indicating the PV potential elimination without electrode contact is feasible with a PFA application. So this is Dr. Barmer, the 1 year follow-up data published circulation last year. PFA, 66% at 1 year, and the persistent AF 55% at 1 year. So average application, 48 application, 4 trains over the 9 electrodes. This may not be very accurate, the translation, but if you think about like a focal RF ablation, it may be like a 1,728 focal application of PFA. That's a lot. So now talking about the mechanism of the myocyte injury by PFA, applying a high voltage, short duration, increased membrane permeability, or physically you make a poration on the lipid bilayer. Of course, disturbing ionic channel, producing conduction block very easily. Problem the membrane repair. This is a reversible electroporation or transient conduction block. For EP standpoint, that's not good news. Increasing the dosing, and you make a great operation, initiating ATP leakage, but as long as mitochondrial activity preserved, still transient conduction block. Further increased dosing, now they're damaging the mitochondria and the DNA, initiating irreversible lesion due to the apoptotic pathway. Finally, further increase membrane rupture, calcium influx, resulting in the contraction band necrosis, swelling, hemorrhage. It is complicated. It's compared to RF simple thermal injury. PFA is completely different. So this is the data we published the SAC-EP, working with the cardiofocus, the galvanized people. This is 2 hours after the PFA application using their system, Centauri, with contact with sensor catheter, and then 35 amp application, average contact is 18. This is cross-section left ventricle. There are 3 layers. We call the central, dark central zone, historically showing the contraction band necrosis, hemorrhage, and edema. But there's no coagulation necrosis indicating no or minimum thermal injury. Pale zone means no TTC staining, indicating mitochondrial activity is gone, and the histology is showing the pycnotic nuclei consistent with DNA and the mitochondrial damage, indicating apoptotic zone. So those two zones is irreversible lesion formation. But unique stuff, look at the hyperstain zone. Histologically unaffected normal myocardium, but the hyperstain means that TTC means the mitochondria is active. The membrane permeability increased, therefore hyperstain. But this area, the reversible or transient conduct zone, that is a problem PFA. So therefore, the durable lesion size measurement, we combine the dark central zone and the pale zone. For summary, irreversible versus reversible lesion formation. This is the RF ablation. This is a nice study, 1995, published by the Dutch group, the De Backer and my friend Frederick Kampf. Irreversible zone surrounded with very narrow reversible zone. In contrast, PFA application, if you make a similar lesion size, durable or irreversible zone, but it's surrounded much larger reversible zone, i.e. transient conduction block. So now I'm talking about effect of contact force. Contact force, it's very important RF, so therefore we developed the horsepower time index, ablation index, to predict lesion size. Like the last 3-4 years, people talking about PFA is contact not important. I'm not sure. Actually, there's not much data. Effect electrode tissue contact for the lesion formation PFA, especially beating heart model, has not been well validated. So therefore, we performed the study using Centauri, cardiac focus, galvanized the current control system, applying a biphasic microsecond application, monopolar delivery, using contact force focal catheter, which is the Abbott catheter. So the protocol is simple. Right ventricle, we are applying 28 amps, LV or greater 35 amps. We change the contact force from 4 grams to 55 grams. Low means at 90.5 grams, and moderate contact force 20 gram range, high contact force 40 gram range. Also, we perform the non-contact ablation intentionally, confirmed by the electrode just 2 millimeter away from endocardium, confirmed by eyes, also contact force tracing. So that's ablation without contact. During a PFA application using this system, there's no microbubble formation, which is good news. So this is data, contact force from 5 gram to 50 gram, lesion depths increased from 2 millimeter up to 7 millimeter at the 20 amp application. Greater application of 35 amp, lesion depths increased from 2 millimeter up to 8.5 millimeters. Significant nonlinear correlation with contact force and lesion size. Importantly, 1 or 2 millimeter away from endocardium in the beating heart study, no effective lesion formation, period. So in summary, during a PFA, electrode tissue contact is required for effective lesion formation. Lesion depths increase significantly with increasing contact force and the number of PF application from 2 millimeter up to 80 millimeter. Better not ignore the contact force information. Impedance decrease, electrode temperature during a PFA, a poor predictor of lesion size. So this is just 1 minute more. This is like a multipolar, PFA catheter, which is a fair pulse. They have like a 5 spine, 4 electrodes in each, so they have a total 20 electrodes. And the company saying, for the PB, you might do the 4 application at least, basket configuration, and another 4 application at least, flower configuration. 1 application actually the 2,000 voltage, 200 milliseconds, 5 times over the 20 electrode. So this is a 1 packet, eliminate all PB potential. This is the average case, okay? So the PBI, total 42 PFA application. And if you want to go posterior ablation, another 25 application. After the ablation, all potential gone. But if you calculate the focal ablation, 60 times 5 pulses, 20 electrodes, it's a 66,700 focal PA application. This calculation may not be accurate, but you can get some sense. We're doing a lot. So the problem, the PFA without the contact force information, all right, we know that rapid elimination into cardiac electrum or even termination of tachycardia does not indicate reverse lesion formation, unfortunately. Then you might say lower risk of collateral injury, phrenic nerve injury, esophagus injury. we admit it's lower than the RF application. You might say, why don't you ablate more, push catheter more, but result in the ALH syndrome? That stands for ablate like hell syndrome. So here's the ALH syndrome. Acute kidney injury related to the hemolysis after PFA, like using this catheter, more than 100 fair pass application result in severe acute kidney injury, and they're reporting if you go more than 70 applications associated significant hemolysis. That's actually, my calculation, 7,000 focal applications. So again, the ALH syndrome include the acute kidney injury due to hemolysis. PFA without electrode contact, not making effective lesion. However, you injuring red blood cell effectively. That is a problem. And as you know, if you ablate like hell 30 minutes, you can eliminate entire left atrial potential. But resulting in stiff ALH syndrome, maybe stroke risk increase. You're talking about DC ablation, maybe heart failure, also like a DC ablation, physics not much difference for the PFA versus the pulse field ablation. We know there was some adverse effect, which is the pro-arrhythmia effect in DC ablation. We don't know PFA yet. In summary, PFA lesion associated with a large area of reversible injury, i.e. transient conduction block zone. During a PFA, elimination, electrolytes, termination tachycardia are not reliable indicator for durable lesion formation, giving us the false sense of efficacy. PFA without contact information may lead to extensive ablation and ALH syndrome, hemolysis, stiff ALH, which is a false sense of the security issue. PFA without electrode contact should be minimized because not making a durable lesion, but the risk of hemolysis may increase. Finally, the tailor-made approach based on the contact force and number of PF pulses to control irreversible lesion size is desired to enhance efficacy and safety of PFA. Thank you.
Thank you, Hiroshi. I know you have to leave, but just one question, if you can take it. It came from the audience. So you make a very compelling reason why we feel we should be touching the tissue at least and have some force. But the question is, what if you just turn up the voltage? Can you overcompensate that?
Yeah, if you have contact, increasing dosing, yes, you make a greater durable lesion. However, you're starting further greater transient zone. All gone, then we have no idea. All right? So that's a fundamental physics voltage gradient. Even increase, yes, durable lesion size increase, but reversible zone also increase a lot. That's a problem. Thank you. Good question.
Thank you. Okay, Hiroshi's going to leave for a session he has to present, but I'd like to welcome David Kenigsberg from Florida. We've spoken about contact. He's going to talk about why direct endoscopic visualization, specifically using this ultra-compliant balloon, how it can be beneficial. So, David?
Thank you. So we exist in a very exciting time in electrophysiology where we now currently have 4 energy sources. I'll remind you, those are radio frequency, cryo, laser, and now PFA. Currently, all the rage is about PFA, but I'd like to express my experiences using this compliant balloon as a laser balloon with having done over 600 cases since 2019 when I adopted this as far as my pulmonary vein isolation strategy. I'll talk a bit about why I chose this, how an ultra-compliant balloon compares to other technologies and why I feel it's superior, what it allows us to do with the endoscope as far as visualization of the pulmonary veins, and how the importance of contact leads to durable clinical results. I'll remind everyone in this room that whereas PFA is fresh to market in the United States, we have durable lesion data with laser, in my experience, for over 5 years. And I'll discuss briefly my zero flow or workflow with the balloon and the adoption thereof, and a bit about the future, and I'll do all of this in about 8 minutes. So as far as direct visualization, to the left of the screen you could see lesion quality depends directly on how much contact we have. And in this picture, the center of the picture shows the blood pool in the vein, and then surrounding it there's blood as well. If you have the balloon fully expanded, you can, in a single shot or single pass, isolate a pulmonary vein, in this case, the left superior pulmonary vein. As an electrophysiologist in 2024, given financial constraints, we should not be talking too much about speed, but I could tell you that this is a reliable tool to isolate pulmonary veins reliably in less than an hour if you're skilled at using the balloon. And the benefit of the ultra-compliant balloon is that it can fit any vein at any time from 7 millimeters, like a right middle pulmonary vein, up to 43 millimeters in a large left common. So the importance of direct visualization allows me to know a bunch of things. First of all, as I mentioned, I'm pluralist, so I can extend this balloon in its unexpanded form with the tip that is extremely atraumatic into any vein, and then I can expand and fully expand the balloon in the vein and know which vein I'm in. So this vein looks exactly like the left superior pulmonary vein. It shows you that I have circumferential contact, the white being the vein portion that I'd like to ablate. I can move the tension slider so that I can provide energy at any point in the vein. And this can be done with a single shot with no edema, and the energy can be titrated between 13 watts posteriorly and 15 watts anteriorly on the ridge if necessary. Now, if you don't have adequate contact, you're not going to be able to provide effective isolation, just like with any other energy source. So this depends on where you do the transeptal puncture and also how you select a sub-branch with the atraumatic tip. And in some anatomies, there's more challenge considering large left atrial size or non-standard venous anatomy, like as if you have a right middle or left common. However, I will mention that with this technology, all of these are approachable. What's interesting is that every single vein has a footprint that is common amongst all the veins of that type. And I did not know that before I started using this balloon and getting used to the endoscope. But the left superior pulmonary vein kind of has a comma shape. The left inferior pulmonary vein looks like the continent of Africa. Right inferior pulmonary vein like an eyeball, and the right superior pulmonary vein like a jelly bean. And this is my experience with isolation of the left common pulmonary vein. You could see a nice ice image with the balloon fully expanded, providing a nice antral isolation of the vein with the laser at 15 watts anteriorly and 13 watts posteriorly. Here's a right middle pulmonary vein, which I think is under-recognized with standard prior ablation approaches, especially with RF, even with high-density mapping. Here with the endoscope, you can clearly see the early branching of the veins on the right side and a distinct pulmonary vein ostium in the right middle location. And with a 7 millimeter balloon, you can fully isolate that vein by itself. The left superior pulmonary vein has a distinct view, as I mentioned. The left inferior pulmonary vein here, you can see to the right of the screen, the ridge extends up to the left superior pulmonary vein so that you can provide an adequate isolation of all veins and have contiguous ablation in the veins. This is the right superior pulmonary vein, which can easily be isolated in a single shot, as this is usually a circle when you have good contact. And finally, the right inferior pulmonary vein, which for some balloon technologies is challenging, especially cryo, to put the balloon appropriately in the vein and get complete circumferential occlusion. But here with the endoscope, you can directly visualize your contact with this vein and show that you have good circumferential contact so you can provide an adequate lesion. The laser provides for a rapid mode that allows us to go, again, in a single shot around each of the veins, providing good contact. So why did I use the CardioFocus HeartLight X3 balloon since 2019? Well, PVI is a necessary and established endpoint for AF ablation, for any type of AF ablation. If you don't have adequate PVI, you have nothing. And it's reproducible. The laser balloon allows for reproducible antral isolation in less than an hour routinely in skilled operators. It can be done pluralistically. The results of that have been published with Dr. Wang's group out of Rush. It's safe compared to other energy sources for phrenic nerve and other potential complications were extremely uncommon and rare. It's extremely efficacious, and in my opinion, in my hands, maybe better than other existing energy sources, and time will tell how it compares to PFA in its infant growth. And it's versatile. The compliant balloon can handle any and all PV anatomy, as I mentioned, from 7 millimeters in a right middle to 43 in a very large left common. I call it the smart man's balloon. So why is that important for a talk where we're super excited about PFA technology? Because this same balloon provides the structure and framework for the next generation balloon, which will allow for the delivery of PFA. And I think that this tool, having used it in a swine model, will provide an excellent single-shot source to do pulmonary vein isolation with PFA. And this is my experience in a swine model. The one point of this slide is to mention that with the splines, you can actually adequately map where your balloon is in space and create a fairly decent 3D electroanatomical map with the electrodes. I think, in summary, for the cardiofocused laser balloon and now the next generation with PFA, the future looks bright. And I think that we will see a lot more of this to come. And I thank you very much for your time and your attention.
Thank you, David. I think a couple of the impressive things we've seen is we're on time, especially considering Hiroshi spoke, and we're still on time. But I thought this was a great time just to ask you a question or two since we have some time. I think many people in the audience have probably never endoscopically seen inside, and when you do one of these cases and you can actually see the tissue, it's quite impressive. Can you talk to us a little bit about the learning curve, because you're obviously very skilled at this. Are these pictures of the veins just the ones you cherry-picked for the presentation, or is that something you see consistently? Just kind of give us your little input on that.
I mean, I have about 600 vein pictures probably on my phone, but I will tell you that there is a learning curve to using a balloon in the left atrium, period. And I think that that's true both for cryo balloon, for a laser balloon, and for any spherical technology that is large shape. However, once you are able to realize the pitfalls of not, avoiding pitfalls like not performing your transeptal in the right place, or you know how to manipulate a large bore sheath, I think it's very easy to get consistent contact. So to answer your pointed question, those are typical pictures of any case. If you came to my lab on Monday, I could show you the same pictures.
Great, yeah, and I think the importance, at least in the US, there is a firm entrenchment of loss of experience with fluoroscopy. So a lot of fellows that come out of training, when they have to do PFA and there's no mapping, they're kind of lost because they don't know how to use fluoro anymore. And the fact that the balloon can be compliant enough and you can visually see without having to step on fluoro and know you're making contact because there's no blood around, I think is really powerful, and we'll see. And that leads us right up to Jacob's talk. Jacob Koruth from New York is going to talk to us about this concept of a true single shot. When we say single shot, you hear single shot catheters, but you still need to do 12 applications in a vein. So, I mean, is that really single shot, or is that more of a regional catheter? Let's talk about the concept of actually putting the catheter in one location and isolating the vein.
Thank you, and thank you for the opportunity to be here. Before I move through the slides, I'd like to make one point in that when we have an opportunity of using a tool that we developed in the world of thermal ablation over many years and perfected the structure of the tool to fit different PVs, to make a lesion set that has worked for us in our patients, as you just heard, it's truly nice to be able to take the same tool and then apply a new energy source so that you get the best of both worlds. And I think that's where this change from the laser balloon to the PFA balloon, retaining all the features of the laser balloon, is why I think this particular approach is special. These are my disclosures and a special acknowledgement to our postdocs who will have a poster on May 19th between 9:30 and 11:30 about this technology. Now, you've seen the catheter in the previous talk, but let me tell you a little bit more about this catheter that is PFA enabled. It's a 12 French balloon, 12 surface electrodes, a millimeter wide and 20 millimeters long. A 2 French endoscope like before that allows you to see the inside of the vein, much like you heard with the laser experience. But what's truly different about this balloon compared to many of the balloons out there is the ultra-compliant nature of the PVs. And you know, all these PVs have different shapes. So because it's ultra-compliant, it fits into the PV as opposed to you trying to clock or counterclock to get contact at different surfaces. And I think that's where circumferential contact with one position keeps this balloon different from other balloons. The size, just like before, between 7 and 41 millimeters. And the goal of PFA, and this is still in development, we're doing early preclinical work, is that you place it in one vein, you don't have to rotate, you look for contact so you know where you don't have contact, you give a lesion, and you have a contiguous lesion. Bipolar biphasic is what we were testing in our preclinical lab, and the concept is between odd and even electrodes so that you get really wide overlapping lesions without any gaps. So these are just examples of what the balloon looks like, pretty identical to the laser experience. On the left is the balloon in the SVC with the soft atraumatic tip. On the right is the balloon in the RSPV, a slightly different shape with the roof, but it still engulfs that entire space without leaving gaps. And you can see the soft atraumatic shape bending along the course of the vein and not sort of poking the vein out like stiff balloons do. These are endoscopic views, exactly the same as what you saw, but what you see here different is the splines, which are the electrodes, and you can see how evenly spaced they are. If you see one spline is really pushed apart, then you know you need to optimize or reposition. And when you can actually see contact, there's never going to be an argument about was there contact or is it just being inferred by using impedance. And these are the ablative electrodes. So this is a preclinical experiment where we show you here an SVC at baseline, an SVC post-ablation, and chronically at the end of the month showing that these lesions are durable. And this is what the lesion set looks like. And I think this is one of the, I mean, on the left you see an epicardial lesion set that's transmural. On the endocardium, what you see is a opened up SVC like a book. And what you see is a very wide band of lesions. And I think this is where PFA allows us to get a much higher degree of durability because there's not a lot of room for gaps to occur in a lesion set like this, unlike RF, which are circles trying to meet in the middle. So I think that's a key concept. Bipolar biphasic microsecond PFA. These are pictures of the right superior pulmonary vein on the left without it cut open. And what you can see, it's not just the ostium. You're getting a large antral area that's ablated. And this is what this balloon does. It fits into a really stubby, narrow vein in the swine anatomy, but then opens up to fit the antrum. So if you had a really small RIPV, this is what it would look like. And on the right, you can see a nice wide transmural lesion, just like the SVC. This, it's difficult to appreciate if you've not been doing a lot of animal experiments, but the yellow area that you see to the right is transmural lesions across the Bachmann bundle on the roof of the LA, something that's traditionally quite difficult to do with any energy source. These are 3 examples of the compliant balloon with the electrodes. On the top left, you see an area of perfect contact. So you see the pink region, which is the balloon up against tissue with no blood, all around the catheter. So in this situation, you give a single application and you get one perfect circle of lesions. And in the right bottom, you can see on the top corner of that vein, there is blood. Now, that doesn't mean that PF won't have any effect, but likely not enough of an effect to give you a durable lesion. So that would be a position that you would want to optimize or rotate to get better contact. This is a slide, and I'm going to take you with the first image on the left, which is us looking down on the left atrium with the right superior vein to, I guess, to the right. And what you see is a normal healthy vein. We make a lesion, and if you look at the endoscopic view there, you see that patch of blood, which is an area of poor contact. Despite that poor contact with PFA, as we've learned, you get isolation. We bring the animal back in 30 days, remap, it's wide open on the roof, and when you look at that macroscopic picture that I've outlined with the dotted lines, you see a big gap on the roof of the RSPV. This is why appreciating contact is going to be important. We are literally going to relive the experience with radiofrequency and cryoablation, where we were first very happy with PVI, and 2 years later, when we realized that we can do better, we're going to go take a step backward and say, what can we do during our first ablation to make this durable? Again, visual assessment eliminates contact-related gaps. Poor contact in veins especially are going to lead to acute isolation, but chronic reconnection, the bane of our existence in PVI. And chronically, you can either have gaps that are not transmural or gaps that just exist because you were too far apart. So contact, seeing contact, very important. This is I'm going to end with this just to highlight why contact in tubular structures is important. So in this particular experiment, we turned one spline off just to see what would happen. So that's the post ablation. You can see that the SVC is isolated. Oh, that was odd. And then at 7 days post ablation, it's already reconnected. You can see a band of voltage going through the circumferential ring, and obviously at 20 days it remains reconnected. And this is the pathological sample showing you a nice wide lesion, but a gap. So highlighting why, even though you're acutely isolated at the end of a PFA ablation, if you don't have a concrete way of knowing that there wasn't contact, there is a chance that you'll end up with a chronic reconnection. In summary, by the way, these are examples of mapping systems showing you that these electrodes can be projected on anything that does impedance-based mapping and give you localization if you wanted to use it as a PFA tool with another mapping system. These are examples of tracings from the electrodes that give you diagnostic feedback. Remember, this is PFA, so everything generally tends to look good, so you really need to rely on contact. And the key points, circumferential true single-shot ablation is possible, and hopefully this preclinical data will tell us what dose and regime will get us there. Direct endoscopic visualization of contact is important, like I just demonstrated, and obviously lots more work to be done, but I think we're on the right path to something exciting. Thank you.
Thank you, Jacob. Just a question and a comment. So I think one of the things that everyone's kind of getting fearful for is the hemolysis issue with PFA. And when you have electrodes, regardless of the fact that they're facing internally, the electric field goes behind it, and you have interaction with blood, even on one side that's not making contact. Do you think there's any potential advantage when you're in a balloon type shape because you don't have blood on the other side of the electrode? Potentially this could have a positive effect in decreasing hemolysis.
Yeah, absolutely. I mean, I think if you exclude the blood by using a balloon, all the electrodes that are stuck between the balloon and the tissue are essentially not going to cause any hemolysis. On the back end, if you have some of the electrodes sticking out, a small portion of that will create hemolysis. So I think this sort of a design would technically eliminate the possibility of clinically relevant hemolysis in a case.
Thank you. And David, one question that came up from the audience. Adding endoscopic view is very nice, but cost-wise, is it really affordable? Can we afford it? Are you paying like $50,000 a case, or how cost-effective can you do a case with endoscopic visualization? Is it different? Is it pretty much the same?
It's a lot cheaper than Farapulse.
I mean, even compared to RF and stuff, it's not. People assume endoscopic.
This is probably the same or less than cryo.
Okay, just to give everyone a perspective of that. So, can I take the clicker, Jacob?
Oh, sorry.
Okay, thank you. All right, so now we talked about PFA on trying to develop a single shot, bipolar energy, and really having contiguous lesions with a balloon. But also many people want to have the ability to do lesions beyond that, PVI plus, and have a focal catheter that's big enough that can grip the tissue, that can deliver energy. And so we're going to talk about our clinical experience using a catheter like this that can map and ablate. And you know, this initial image looks at delivering PFA on a solid tip 3.5 millimeter catheter. These were really the first broad commercially used cases in Europe before the currently approved devices, where we were delivering PFA through a focal catheter that was about, a commercially available RF catheter. And you see that you still require a large number of lesions. You're going to do some overlap, and it takes time, but you can do point-by-point ablation. But the whole point of this is maybe we don't need to have that kind of catheter dexterity and skill set, and perhaps you can do something better. And if you could design a catheter, obviously one that you can map with, but that can make larger lesions, and you can just see from the larger tags, you could potentially have the advantages from both sides. You can map well, you have high density electrodes with fewer applications, making the procedure more efficient. I'm not going to say shorter because everyone's sensitive about changing our reimbursement, making the procedure more efficient. And that was the concept with this quick shot catheter. And so this catheter has a 10 millimeter spheroid tip design. So what's great about catheters like this is that when they touch the tissue, they grip it. It's like a tire tread touching tissue. So they're much, much more stable than the solid tip focal catheters. This is irrigated, it's bidirectional, and because it is monopolar, you can put this through a very short sheath, a very low caliber sheath in terms of size, so you don't need a 14, 15, 16 French. This can go through an 8.5 French sheath. And the unique aspects that we studied, as we talked about, is how do you gauge contact? Because we are learning that you need to have some level of contact and not electroporate in blood. And can we gauge better contact versus less contact and how much of a difference it makes? And this system was connected to the Centauri system, the same generator that you can also use potentially for bipolar, but delivering all this through one. And what you see there in that GUI is looking on FACC at the catheter, and you have the electrodes numbered, and you can see which ones of them have a minor change impedance or low contact, and the darker green is kind of a gradation of having higher contact. And so this is some of the preclinical work, and initially, we're just using ice to gauge, so we look on ice, and we see that the catheter is floating, and we deliver an application. Then we have kind of low contact based on a minimal impedance change of 10 to 20 ohms, and then a higher gauge of contact where I'm pushing, I'm changing the morphology of that spheroid tip, and you can see the higher level of contact. And if you looked at the slides that you see in terms of the gross pathology and also at the data, and the very, very far left on the bottom is when you have no significant change in impedance, and you might just barely be touching or just not really touching at all, honestly. And you can see the differences between the lesion depth, which is in the dark color, and the lesion width, which is in the light color. And as your impedance changes, consistent with even on imaging having better contact, you can see how it affects the lesion depth and the lesion width. And the depth tends to kind of plateau a little bit as you get to contact. So you don't need to smush the catheter, you kind of really need to be touching. And then you can also see the width of the lesion as it changes. So this was really encouraging as we thought about going into the clinical first-in-man experience, having this preclinical data. And here you see the difference in the swine model. You see the lesion set that's placed from the SVC doing a line posterior down to the IVC. And you can see low catheter contact. Surprisingly, low catheter contact, but having contact still made lesions, but having high catheter contact made those lesions even better, all consistent with what Hiroshi talked about, what the rest of the speakers have talked about, that catheter tissue contact does appear to be crucial to make effective and efficient durable lesions. So with that in mind, we did our first in-human study, and I have to give special kudos to Ante Anik and his lab in Split, Croatia, and you can see him scrubbed in there, but where this was a single center first-in-human design, really prospectively looking at evaluating the safety and performance of this catheter. And then on top of that, we're also going to remap these patients in 90 days, because I think with pulse field, it's really important. When you have a catheter that hasn't undergone remapping studies, you don't really know what the chronic durability is. And we've learned, and Jacob can tell you more than anyone, if you're a patient, the one study you don't want to be in is the first time using an energy for a particular catheter. Because every time you remap, you say, well, I better modify this for the next patient subgroup. So it's really important to have this invasive remapping data. And we looked at safety from incidence of SAEs, and then also looked at acute PVI, and then looking at chronic PVI. And so with this catheter, you have a 10 millimeter design. So you basically have 5 millimeters on either edge of the central part of the catheter. And while the schematic may not show it, we tried to overlap the lesions so they're 5 millimeters apart. So you kind of have a 50% overlap in this first iteration. So we used that 10 millimeter spacing, and that's the size of the lesion tags that you see there on that animation. And the other unique important thing to know is even though this is monopolar, the patients were done under deep sedation of propofol. No intubation, no need for paralytics, which is what we've seen in many of the other monopolar configurations out there commercially. And so that was an important thing that we tested, and there was constant irrigation. And you see the settings were the same anterior, posteriorly in terms of the current. So basically 2 cohorts. We looked at one cohort where we just use ice without contact detection, and we all are fairly narcissistic enough that we think we're really good at what we do. And so obviously we thought just by ice alone, we know it's touching, we feel like it's touching. You see the 3D mapping below. And then we had a second cohort where we use ice plus contact detection. And so here you can see on the left the video just showing how you can use this catheter to make a really high resolution, high fidelity map baseline fairly quickly using a 3D mapping system. And you can delineate your anatomy. And it's really nice to have one catheter that does both things so you're not exchanging catheters, and also decreases the cost per case when you're not using multiple catheters. Here you see the same catheter now after you've created the anatomy, making PFA lesions, and we're tagging them. And I think in the beginning we probably were a little bit lackadaisical about having the right distance and overlap, and we kind of learned that as we did more cases. And here you can see a remap using the same catheter after you've delivered these lesions. So here you see, again, the efficiency is there if you can do things. And the things that affect efficiency in pulse field is the number of seconds of an application. So if you have to give a 15-second application, that's going to change your efficiency if each one is 15 seconds, and that's the way the waveform's tuned. If it's short, and as long as the lesions are good and you're not getting skeletal muscle fasciculations, you're not getting arcing, you're not getting bubbles, then that's going to make your case much more efficient. And so here's our data. And if you look at the characteristics, these are 20 patients. All of them on the very left baseline underwent deep sedation only with propofol. And depending on your country and regulatory reasons, in the US, most of us need an anesthesiologist for propofol. And in many countries in Europe, there's a nurse-driven protocol. But the amount of degree of anesthetic required when you don't have to put a tube through the vocal cords is substantially less. Important to safety, we didn't see any acute safety events with all of those things you see on the screen, including anything procedural or device-related, ST changes, and importantly, no microbubbles. So let's look at the performance results, and we've kind of highlighted the last column. And I think this is important to know. If you look at cohort 1 and cohort 2, and you see all these procedures, the PVI ablation time was about 30 minutes. First pass isolation was commonly achieved, so 90% of the cases when you actually did with ice or with ice in contact, you got really excited because 9 out of 10 times, the first time you've ever used this catheter in a human, still learning how to use it, you were getting isolation. But what's important is what was the 90-day durability, because what you look at the very, very bottom, 90-day PVI durability in total number of PVs, even though you had acute isolation of 90% when you thought you were in contact with ice, look at the durability, about 40%. So 60% of the veins had reconnected, and that's why, again, why it's important to do these studies in remap. Yet with our experience, if we were to use contact sensing, as described with the algorithm, then you can see that the 90-day PVI durability, again, with our first experience with this catheter, was in a fairly acceptable range. Not where we need to be better, but we're already in a good range, but telling you the importance in this design of having contact sensing. And I think it was important is when we looked at the remaps to see where did people reconnect and what happened on these patients. It was usually related to having a gap. The lesions were fairly contiguous, but all it takes is one gap, right, to have reconnection. And these tended to be in regions that were difficult to assess, like the ridge. if you didn't have contact sensing, because it's a complex structure. You don't know how many electrodes are touching. You think you feel it. You look on ice, you have a thin slice, and you think the electrodes are in contact, compared to when you have something like you see in cohort 2. So there's a lot of learning that has happened and much more we need to do, but it just kind of goes over the concept of why contact is important. And so if you look at the cohort looking at a solid tip focal catheter delivering PFA from the same generator for both, and you look at solid tip 3.5 millimeter commercially available standard RF catheter versus using a large tip focal like QuickShot, you can see that the difference in number of applications. You can see the difference in PVI time because you have to move, you just make larger lesions. And you can see that in both cases, durability is good, but we can get better, especially if we modify all the variables and get more experience. But I think contact sensing is crucial in terms of the data that we've seen. So key takeaways, you've seen the clinical results. I think obviously we need to still modify and optimize dose and contact detection algorithm, but we're certainly on the right direction. And I think we all agree in this panel that just doing pulse field and blood with 5 million volts is not the solution. It's really making contact and utilizing the generator to deliver the right waveform so you can minimize collateral damage, at least in terms of hemolysis. So thank you, and with that, Jim, I'm gonna hand you off and give you the perfect amount of time for your presentation. Thank you. Can we go to Jim's slides? Thank you.
Yeah, thank you very much. So in the remaining 7 minutes and 50 seconds, I get to review the clinical data with pulse field ablation today and take a look ahead. These are my disclosures and a disclaimer that CardioFocus doesn't particularly endorse some of the off-label applications I'll be discussing in this session. Now, pulse field ablation is emerging as a game changer in AF ablation, and there's a growing number of devices out there available for use in humans, most of them single shot, but also a focal device. PFA holds a great promise for ablation due to the potential for myocardium preferential ablation, but it has been difficult, honestly, to fulfill that promise in terms of better clinical efficacy. For the sake of time, I'll limit myself to this recent meta-analysis of 18 studies comparing PFA to RFA, comprising 5,000 patients, and they found a very small signal towards a lower treatment failure with PFA. PFA procedures were faster in exchange with these largely single-shot procedures. There was a higher tamponade rate and longer fluoroscopy exposures. However, if you look at the studies with mandatory remap procedures, I think there is a clear signal that PFA procedures provide better PVI durability, shown in the purple bars, than cryoablation and radiofrequency in the red bars, regardless of whether it's by number of isolated pulmonary veins or on a per patient basis. And I think this is very important. Every new device, every new pulse design out there should be held up to the standard of proving lesion durability. One of the methods that has gone through this rigorous testing is the focal pulse field delivery by the Centauri generator, now from CardioFocus. This is a generator that basically gets inserted into your normal lab and workflow. You just replace the RF generator with a PF generator. This generator delivers monopolar dosable waveforms through your standard force-sensing catheters. It's compatible with Carto, Insight, and Rhythmia, although the integration is still imperfect. You have to deal with a number of errors. It may be a matter of temperament, but personally I can live with that in exchange for efficient pulse field delivery. You use your usual workflow, small sheet sizes, and there is documented durability of PVI in in a remap study, the pivotal one being this one, the Eclipse study driven by Ante Anich and Johan Feigen. What you see on the left is the dose finding phase of the study. And then in the right bar graphs, the PV durability with the optimized waveform with the 3 catheters testing across the bar, 89% PVI durability. Although the clinical 12-month follow-up data are not yet published, I've been allowed to share this. There's a 93% freedom of AF in patients with the optimized waveform. This is not a single procedure outcome, obviously, since patients with reconnected veins were re-isolated during the remap procedure. But in a smaller series from Hamburg with intermediate freedom from AF, they found freedom from AF in the high end of the expected range, I would say, with this method. Now, moving on to our experience in Copenhagen, we started early on after CE mark in 2022, and we saw this as a versatile tool really for all atrial arrhythmias in conjunction with high-density mapping. With this, you can do pulmonary vein isolation de novo, obviously. This is a point-by-point procedure, so not much faster than an RF ablation. But what you get is a very high rate of first-pass isolation, be it PVI, and you avoid almost contiguous lesions on the posterior walls. It's like you sometimes see it with single shot promoting roof-dependent flutters. Now, you also see a very high rate of first-pass isolation of posterior wall just by a roof line and an inferior line, no need for ablation in the box. Be it de novo or be it in a remap procedure. And this is very applicable to any linear lesion. You get first-pass isolation, mitral isthmus, catheter cuspidismus. These are the summary data of the acute procedural results. Of note, at the bottom of the table, you see first-pass isolation, 99% of PVIs, 100% of any isthmus targeted with this method, and overall 98% first-pass effect of ablation. We have since gone on to do 229 atrial tachyarrhythmia procedures, including complex redos of atypical flutters with an average procedure time of 106 minutes. In terms of safety, we had 1 transient AV block ablating on the anterior mitral isthmus, 4 cases of ST elevation despite nitroglycerin, but that was managed without clinical incidents. 2 tamponades, unlikely to be related to ablation. We have no recurrence data yet. Unfortunately, it's under evaluation, but we have noted that redo rates are very low. This slide shows you over the same period of time redo rates with thermal ablation on the left bars and with focal PFA on the right. And there's a I think quite impressive, although it's not randomized data, 6-fold higher redo rate in the thermal ablation group. So I don't have very many repeat procedures to show you, but in the 3 out of 229, 2 had intact previous lesions, and 1 had solitary gaps in previous lesions. We have since moved on to use this in the ventricles, which was a goal up front, including in previously failed RF ablations. And I think this case was particularly convincing to me. We had spent all morning trying to ablate a LV Summit PVC with RF from the endocardium and from the distal CS. Then had the opportunity to switch to PFA. And you see on the right the result of the first application from the endocardium. You saw an acceleration of PVCs and then elimination that was durable. So this was the same patient, the same PVC, the same day, the same operator. All that was different was the energy delivery and a marked difference, really. So we're using this increasingly for VTs and PVCs in about 30 procedures now. I want to switch quickly to another application from Ante Anich's lab. You can use this for accessory pathway ablation, particularly elegant from the CS, just 1 catheter no need for transeptal or retrograde approach. So coronary vasospasm remains an issue also with this version of the technology, but I think it's a concern more than a complication at this point. So in conclusion, PFA is emerging as a main ablation method due to a favorable safety profile. Safety remains an issue with the large single-shot devices, and that may not apply to focal PFA by standard catheters. It's characterized by high acute procedural success, very effective at first pass efficiency. It has become our go-to tool for repeat procedures or planned PVI plus procedures. It's versatile also for ventricular arrhythmias. You have to give nitroglycerin when ablating near the coronaries, and there is a need for anesthesia or deep sedation with propofol. So a quick look ahead. It's difficult to make predictions, especially about the future, but it helps that it's almost here. I think focal PFA is an attractive tool, in particular for ventricular arrhythmias. I hope we'll see better integration into mapping systems. There'll be a further development in catheter design and pulse field design, but we also need a better understanding of lesion formation and methods for enhancing those lesions. And very importantly, a method of assessing lesion irreversibility. But I remain a believer that this will be an ablation modality of the future. And to end, I would like to plug our LinkedIn website where we post a lot of these interesting procedures, primarily by Martin Haldale, our star technician. And with that, thank you for your attention.
Great. Thank you, Jim. Thank you all for attending. There are a lot of questions which we're not going to be able to get to, but one question that keeps coming up is, how does the voltage with this generator compare to another one? I just want to remind everybody, it's not, radio frequency is one of those where you can compare one 3.5 millimeter tip versus another, because the frequency is very similar. It's not about just, it's the waveform, it's the generator, it's the form factor. There's so many complexities with PFA that it's not apples to apples, it's always apples to oranges. So just please keep that in mind. And again, thank you for attending.